Okay, good evening, everyone. Can you hear me?
Good evening, Prof.
Good evening, sir. Good evening, Prof.
Good evening, Prof.
Thank you very much. So,
Good evening, Prof.
good evening, Prof. Please mute your mic so that we can.
Good evening, Prof.
Good evening, all of you. Yeah, you're all welcome. So we'll just quickly, I'm sure you will have read through this, so I'm going to be fast. Yeah, so please, we're going to look at prevention strategies for communicable diseases. Then tomorrow we'll have to look at common non-communicable diseases, right? So today I've listed quite a number of them. I'm sure you have the slides and I believe you would have read them. It's been with you for a while, as if you had time. So today we are going to look at starting from malaria, which is commonest, malaria fever. Many times our people will say common malaria. It's interesting. Malaria is not common. It's the greatest killer of humans in Nigeria and in most African countries. Okay, so malaria is actually a life-threatening disease and is caused by malaria parasites, and they are transmitted by the female Anopheles mosquito, not male. The male just sucks juice, that's and nectar. But female Anopheles mosquito, depends on blood meal. So in the process of blood meals, then it transmits the Plasmodium parasites. There are 5 common parasites: the Plasmodium falciparum, vivax, ovale, malariae, and knowlesi. These are the 5 commonest ones. But of these, falciparum and vivax are the most dangerous. They pose the greatest threat to Africans or to humans. Plasmodium and vivax. Falciparum, I'm sorry, falciparum and vivax. The deadliest of them, of course, is falciparum. Falciparum is the one that is commonest where we are. Vivax is predominant in most countries outside the sub-Saharan Africa. When you go to North Africa and towards the Mediterranean, but in the Mediterranean, you now have all that. Okay, but in sub-Saharan Africa, you have. Oh, please mute. Oh, please mute so that we don't disturb each other. All right, so WHO has classified malaria. It proposes classification based on the endemicity. And the endemicity here is talking about the continued presence of the parasite in our society. And the easiest way to identify their continuous presence is to measure the rate of enlargement of spleen in children that are aged 2 to 10 years. The reason is that with attacks of malaria, the spleen is also an organ that is defensive. It's a defense organ in the body. So the spleen tends to also fight the parasites. And one of the ways it reacts by getting enlarged. You see, in order to produce some cells that will attack the parasites. So, but if after many years and several bouts of malaria, the spleen cannot, the parasites actually overwhelm the spleen. And what do we have? The spleen begin to shrink. So that is why in adults, it's difficult to palpate the spleen. Normally, the spleen is such an organ. Whenever you examine somebody, it's difficult for you to touch the spleen because the lower rib cage covers the spleen. Anytime you are, for those of you who are, any of you who are clinicians, you see that anytime you are palpating the abdomen and you're able to touch, feel the spleen, that spleen is enlarged. That shows a sign of spleen enlargement. Otherwise, it's not reachable by your hand. Whenever your hand is able to touch it, then it means it's enlarged. So in children, we measure the spleen rate by the enlargement of the spleen. So if a survey is made, and if you say out of 100 children, you measure the spleen rate of 100 children aged between 2 to 10 years, and if 10% of those children have enlarged spleen, then we say such a place is hypoendemic. If the spleen rate is between 0 to 10%, it's hypoendemic or hypoendemicity. It means that malaria parasite, though is there, but is not as widespread in that environment. Then mesoendemicity is talking about when the spleen rate is between 11 to 50% of the children. If nearly half of the children have enlarged spleen rate, then malaria endemicity in that place is referred to as mesoendemic malaria. Then if the spleen rate is present and is constantly over, is between, sorry, it is not made this, it is between 51 and 75. There's a mistake here, I didn't correct it, sorry. You know, is between 51. Okay, sorry, let me just correct it at once. It's a mistake. It's between 51 51%. If the spleen rate is between 51 and this, and then it is said to be hyperendemic in endemic state. Then if the spleen rate is constantly over 75, then in that case, that is where we have holoendemicity. It's called holoendemicity. Like Nigeria and most West African countries, that is where we are. The spleen rate of children 0 to 10 years in our society is constantly above 75%. It means that if we take 100 children in our society and examine them, we should expect to see at least 75 of them having enlarged spleen. But then this spleen rate, even though enlarged in children, in adults, it is very low, it's not palpable. And this is because of repeated infarcts. Infarct, that is, I don't know how to explain this again. It's a pathological term, which means when, because of the parasites, blood supply to the spleen is reduced and a lot of dead cells begin to shrink. So that's what is called infarction or infarcts. So WHO has estimated that not less than 250 million people thereabout of malaria cases occur annually. However, African region has the highest proportion, is disproportionately higher in the African region. Well, and maybe it is so not because we have more mosquitoes. It is simply so because we have not been able to eliminate or gone far in our malaria elimination. We have not made much progress. Malaria has always been a global problem, a global problem. Those countries where you don't have malaria today didn't say that, oh, they never used to have malaria. No, they were like us. They were like us. But over many years, they succeeded in eliminating the um, parasites in the environment. The mosquitoes are there, but the mosquitoes are not parasites laden. They are not carrying about the plasmodium as it were in our own environment. So that is the difference between the mosquito we have there and the one we have here. The female Anopheles mosquito, even though not common there, the other variants, they feed on blood meal, but the thing is that in the process, they do not transmit malaria parasites, okay? So that is why. So malaria actually has a very high burden of morbidity. A lot of people, one way or the other, are sick of malaria, and that prevents children from going to school. It prevents people from even going to work. And you can imagine when people are prevented from going to work or do their business, there is some economic loss, of course. So malaria has a lot of huge economic burden in our country. In fact, health economists have quantified it to be not less than 3 billion naira, 300 billion annually. Okay, so, but in terms of mortality rate, it accounts for about 20% of all cause mortality. That is mortality from all causes. If you put them together, malaria accounts for about 20%, especially in children age 5 years and below. It is deadliest among children. In other categories of people, as you will see later. 4 countries account for over half of all malaria deaths globally. And those countries are: 1, Nigeria, leading the pack, followed by Democratic Republic of Congo, United Republic of Tanzania, and Mozambique. These are far smaller countries without much financial endowment as Nigeria is. Like Congo is always plagued with war. Mozambique is a very small country, also a lot of insecurity and war plagued, just as now in Nigeria, so that's where we are. The common symptoms are fever, headache, chills, and all that. They usually appear about 2 weeks from the time of an effective bite of a mosquito. Okay, and it progresses to severe malaria if nothing is done, and can lead to death, particularly from cerebral malaria. People can go into coma, confusion and coma, and die. So for people, those people who often say, oh, not be common malaria, please, they should have a rethink. Malaria is not common. Malaria is a very serious issue, and we should treat it as such. We should treat malaria as such. Okay, so the most vulnerable groups when it comes to malaria are children, infants, those from birth, well, let me not say from birth, from 6 months, because children who are newly born have some measure of immunity. That's why you hardly can see malaria in a newborn, in a neonate. It's practically impossible to detect malaria in a neonate, because the children are born with some form of immunity from their mother, transferred immunity from their mother. But this immunity wanes, around when the children are the age of 6 months. So at that time, they're on their own. The immunity they acquired from their mother, passive immunity, of course, wanes, and they can now get infected. So infants, those below 1 year, and children generally under 5 years of age, they're the most vulnerable group. They're the most vulnerable group. Then pregnant women are also very vulnerable. That is why we have very severe malaria in pregnancy. Malaria in pregnancy can be deadly. And that is why there is prophylaxis. That is why there is a prophylaxis to ensure that women, when they are pregnant, are being treated with, anti-malaria. Okay. Oh, sorry. What's something here? All right. So, okay, another group of persons, people who have immune compromise, people who have low immunity, either from HIV infection, TB, chronic diseases, cancer, diabetes mellitus, chronic kidney disease, severe hypertension. In all of these cases, and if they are elderly with other intercurrent diseases, people with multiple organ failure, either from prolonged illnesses, one after the other, okay, they are very vulnerable. They are at risk of malaria. The same thing with migrant workers. Workers who are usually, by the nature of their profession or vocation, are always on the move. Mobile populations, migrant workers like maybe fishermen, oil workers, and something like that. Sometimes even travelers can also prone. Then refugees and internally displaced persons. When people are displaced from their regular abode, they tend to lose, their own regular preventive measures and things. Maybe people are now housed in camps, open field and all that. So that can be an avenue for malaria. Well, the country is doing much about malaria. There is National Malaria Strategic Plan, okay, which is ending up this year, 2025. So the country will be thinking of, a new strategic plan, and the plans set out clear, specific objective. I believe the next one now is the evaluation of that plan to see what impact it made. The first objective is to improve access and utilization of vector control intervention to at least 60–80% of our targeted population by 2025. Well, these are all the set out targets from 2021, but I can tell you that we did not achieve most of these targets because honestly, I was part of the consultants that did the mid-term evaluation in 2023. Yes, 2023. By mid-term, we were still because we tried to evaluate this plan, see what the country. I did it under the auspices of Global Fund, and National Malaria, WHO National Malaria Control Program. So I was part of that assessment. The evaluation, midterm evaluation. Okay, so that is just what we were not. But I don't know. Maybe if I'm going to be part of the final evaluation, because the start of the final evaluation will begin to come early next year, when at the end of 2025, so the machinery we put in motion from early next year to now see what did we eventually achieve after we operated this plan 2021 to 2025. So several specific objectives, you have them, they are very, normally we write a lot, we are educated people, we have great plans, but many times they also, they do not materialize to something very tangible. Okay, here I say improve the generation of evidence from decision-making for decision-making and impact through reporting quality malaria data and information from at least 80% of health facilities, both public and private. I can say for public, that target can be achieved for public health facilities. I believe more than 80% are reporting, including primary health care centers. But this target is not achieved for private facilities. Only very few big private facilities are on that reporting list. So that's how the rest are. So looking at the various control measures, okay, looking at the various control measures, vector control is one of the most important preventive measures. And these are the two core interventions in vector control. That is the use of insecticide-treated bed nets. Some people call it long-lasting intestinal, but that terminology has changed. All of them, when people were saying long-lasting, that was a few years back when there were all types of nets. But all those nets are no longer everywhere now is the long-lasting one. Everywhere is so calling not long-lasting is more or less not so useful anymore. It's just insecticide-treated nets, bed nets, okay? And indoor residual spraying of walls. The aim of indoor is just, when after a blood meal, the mosquito vector tend to perch somewhere to rest. And by the time it perches on the wall, that wall has, permethrin, which is one of the drugs that is they're used to impregnate the net. Okay. All right. Apart from that, there is progress in global control, but there is a progress. The progress is threatened because of resistance. The progress in control is actually threatened because of malaria resistance. That's a major issue. Major issue. Malaria resistance. It's a major issue now. The WHO report says about 78 countries have reported resistance to malaria. At least one of those 4 commonly used chemicals that used to treat the nets. So, and then in 29 countries, mosquito resistance was reported to all the main insecticides. In 78 countries, at least one of those insecticides, they are resistant to it. But in 29 countries, almost all the insecticide. But this burden of the insecticide is mainly in the Mekong region. The Mekong region in Southeast Asia, around China, Laos, Myanmar, and the Mekong Valley. That's the greatest place where you have this. So the prophylaxis measures: 1, intermittent preventive treatment, pregnant women, then prevention of the use of seasonal malaria chemoprevention. We also implement that in Nigeria now. The mass drug administration, but we are not doing mass drug administration. Our country refused to accept that because of the question of drug resistance. The question of drug resistance, to prevent abuse, drug resistance. If it is drug resistant, it can be very problematic. Even intermittent treatment for infants, we are not, but for pregnant women, chemoprevention, seasonal chemoprevention, we are doing that. Okay, this in vector control, prompt diagnosis and treatment, and of course, treating all confirmed cases with ACT, that is artemisinin-based combination therapy. All right, very important. Here, WHO actually advises that treatment should always be with evidence. All right, so one of the good things concerning malaria programming is the availability of malaria vaccine. The RTSS, RTSS vaccine. Some countries is being implemented in Ghana, in Kenya, in Malawi, even now in Nigeria. So we started piloting it, okay? The vaccine has been found to be very useful. When it was first tested, it was found to be that it significantly reduced malaria, and severe life-threatening malaria in young children. So, but the fact is that it is not 100% protective. This vaccine was found to be about 60. The best of the ones so far is the RTSS, found to be about 67%, the preventive factor up to 67%, but we think it's good enough, right? It's not 100%. That is, if 100 people, maybe 100 children took it, then we are certain you could prevent 67 of them. But what happens to the remaining 23? Okay, 33. So that's it. All right, the pilot is on, and I believe when the National Malaria Control Program is satisfied with all the DC, they can now roll it out. I'm not sure, I don't know. If I was in programming completely, I would have known, but in academia, at times it takes us time to have the latest information. Okay, and one of the things WHO insists is testing before drug administration. But you will agree with me that that is not always the case with us when it comes to malaria. That is not always the case with us. All right, WHO recommends that all suspect cases of malaria be confirmed using parasite-based diagnostic tests through either microscopy or rapid diagnostic test. Rapid diagnostic test is available to us, but microscopy is a little bit difficult for us because for microscopy require a lot of training and capacity. Malaria microscopists are specially trained. Not every lab scientist can be a malaria microscopist. No, there's a program where they are properly trained for it. So, but for the rapid diagnostic test, we can make do with that in areas where we don't have very qualified microscopists to do the, So the test enables health workers to actually differentiate between malaria fevers and non-malaria fever. I can bet you that most fevers people encounter, a lot, well, not most, but let's say reasonable proportion of the fevers are not malaria actually. They are not malaria. There are many things that can cause fever. But in our environment, once somebody feels a bit feverish, tired, and the next malaria, typhoid, those are chemist people diagnosis. They are malaria and typhoid. You begin to wonder where these people got all those things from. Okay, so the primary objective of treatment is to ensure that rapid and full elimination of malaria plasmodium parasite from the patient's bloodstream. Yes, I concur with this last statement. The reason is that I've been to many countries, including when I was a student abroad. When somebody is admitted, maybe an African is admitted for malaria, they made sure that the African or that person does not leave the hospital until every parasite in his body is eliminated. They will continue, they will collect the blood samples, do microscopy, make sure that there is no parasite, then the person is set free. So that can even keep the person as long as 7 days hospitalized. It's not because the person is really sick, no, but because they want to make sure that's the type of control they have to avoid the reintroduction of malaria in the environment. But here, most of our malaria are not completely treated. Somebody has anti-malaria drugs for the complete set for 3 days, and it comes to the chemist and say, "Oh, I don't have money for 3 days, give me 2 days." And they'll just cut it and give to 2 days, and you feel a little bit better and it goes. That is really bastardization of, this is very wrong. Okay, this is the area, the one I told you about antimalaria resistance in the Southeast Asia, Cambodia, China, Laos, Myanmar, Thailand, and Vietnam. Those are the Mekong region, the Mekong sub-region in Southeast Asia. That is where you have the greatest resistance to drug resistance to malaria, this area. But not to say that we don't have it. We have drug resistance, but our drugs resistance is child's play when it comes to compared to those regions. All right, I think, malaria, another information you can get here is that a lot of countries have succeeded in eliminating malaria, even in recent years. You see at least 3 countries in the consecutive, in 2020, 26 countries reported fewer than 100 indigenous cases of malaria, from up to 6 countries in 2000. So in 2000, only about 6 countries could report 100. You can imagine a case with Nigeria report only 100 cases of malaria in a year. So now we are saying that in 2020, about 26 countries reported fewer than 100 cases each in their country. Fewer. So these countries are tending towards elimination. So, countries that have achieved at least 3 consecutive years of 0 indigenous cases of malaria are eligible to be certified malaria-free. They are eligible to be certified, to have eliminated malaria. You see, so, but the hope we have that now for the last 20 years, about 11 countries have been certified. But so that gives us hope, even though we are not near it. Our malaria parasite prevalence is now, the general population about 22%. 22 point, the last time we did is about 22.3% or thereabout. But these are people having 0. Because when we begin to tend towards elimination, it's when we have about 5% parasite prevalence rate. If we have 5% parasite prevalence rate, then we know that we are now heading a journey towards elimination. But for now, we are still about 22.3% parasite prevalence rate. So 11 countries have been certified free in the past 20 years. So in fact, there was a question I asked some students. Is Nigeria able to eliminate malaria? This question does not have a yes or no answer. Yes is correct, no is correct. It depends on how you can put forward your argument. Yes, for instance, is that look at the number of countries that have eliminated it in the past. So if this is like, okay, fine. If these countries can eliminate malaria, then it means that we can also do so. Okay? But no, those who say, somebody say no way. Those who say no, is that then you see the way things are going. For instance, when you have chemists, all forms of illiterate dispensers, everybody is prescribing, then it's chaos, so those are some of the problems. So whichever way this argument goes is correct, because each of them, has a point. So malaria surveillance is the continuous and systematic collection. I'm sure Professor Maduka told you what surveillance is. Surveillance is actually ongoing and continuous and systematic. It must be systematic collection, analysis, and interpretation of data, in this instance, malaria-related data, and the use of the data for planning, implementation, and evaluation of public health intervention for malaria, of course. So improved surveillance of malaria cases and death helps ministries of health determine which areas or population groups are most affected. So when we track data, when we track malaria data, it helps in planning. We know where the problems are most. We see where the problems are most and where they are less, so that where they are most, we can where the problems are most, we can deploy, materials and all that. Well, this is WHO response. Okay, proven measures, long-lasting proven measures. There are many measures people use. You see, at times in the evening, you see some women carry all type of things, all type of things to sell to people, and some of them are mere placebos. There are proven measures. One is the long-lasting nets, insecticide-treated nets. The other one is the indoor residual sprays. Okay, then the intermittent preventive treatment of pregnant women, prompt diagnosis and treatment, because if it's not diagnosed early, it can be catastrophic. Then treatment of confirmed cases with effective malaria medicine. Then, of course, seasonal chemoprevention in some areas that malaria is very endemic, like in Nigeria, in the Sahel region. But now, even in the Middle Belt, there are areas that, seasonal chemoprophylaxis is also now implemented, but more in the Sahel region. Okay, so now the next one is vaccine preventable diseases. We are going to deal with immunization quite quickly. The most significant cause of death among children are, of course, through our recorded history, they have been infectious diseases. Infectious diseases have killed a lot of our children in the past, right? Even in the present. So, but unfortunately, the interesting part is that many of these diseases are actually preventable. They have vaccines that are potent, preventable. You can imagine people of my age, when growing up, we used to hear about Obanje, Abiku, depending from which area of Nigeria or even other parts of Africa. And these terms, with children are branded that, oh, when they are sick like that, some of them even suffer from sickle cell disease and all that. Okay, so the children die a lot. So women kept on having many children. But you can see now that the issue of Obanje and all that, who is talking about Obanje again? There's hardly nobody talking about Obanje again. Why? Most times, most of the things we call Obanje were just childhood killer diseases from vaccine preventable diseases. They were killing a lot of our children because use of vaccine was not widespread, okay, until sometime when in 1974, when WHO brought the expanded program on immunization. If not, use of vaccine was not widespread. A lot of children had polio, a lot of children died from many things. So people begin to call children, when they die, they begin to expect that this one has died before and come back. They begin to give people, because of the superstition, children all sorts of names, vernacular, all sorts of names, So those are some of the things that happen. But today, with vaccines, you find that nobody's talking about Obanje again. Nobody's talking about Abiku again. So where I ask the question, where are the Obanjes now? So they were just vaccine preventable diseases. Okay, so a lot of these vaccine preventable diseases account for a lot of deaths, a lot of diseases, morbidities, and mortalities among children. Children aged 1 to 11 months accounted for about 1.5 million of deaths Okay, while 1 to 4 years accounted for about 1.3 million deaths. So it's a lot, and that is why we use infant mortality and under 5 mortality as economic gauge, or development. Let me not put it a developmental gauge for a nation. If we want to look at how developed our country is, or any other country indeed in the world, one of the first indicators that will be looked at is what is the infant mortality rate in that country? What is the under 5 mortality rate in that country? So those are some of the developmental this thing, So those are the things, because we know that when you strengthen the healthcare system, then these things, fizzle out. So now if we look at our own immunization profile, okay, in my immunization profile, you'll find out that we actually still have high prevalence of communicable diseases. And at the same time, we have a rising prevalence of non-communicable diseases. So we in public health or doing epidemiology, we say that we have a double burden of diseases because we have not succeeded in dealing with the communicable diseases. We are now gradually being encumbered by non-communicable diseases. In developed countries, if you go to UK, Norway, Sweden, you don't have much of communicable diseases, except maybe during the winter flu, any of these coronaviruses, any of these, influenza viruses, sorry. Corona is just one of them. Influenza viruses because of the weather, okay? Otherwise, they have extremely high vaccine rate, and there is something we call herd immunity. Herd immunity is also very common in the environment. Take, for instance, if herd immunity just says that if in a place you succeed in immunizing 80% of immunizable children in that society. Say, for instance, Port Harcourt. If you have succeeded in immunizing 80% of the children in Port Harcourt with, the requisite childhood vaccines, right? Or vaccines to prevent childhood killer diseases, what happens that those diseases will find it very difficult to penetrate into Port Harcourt. Why? Because about 80% of the children are immunized. That is called herd immunity. Herd immunity. But if less than that, then the disease can come in. These diseases are transmitted from one person to another. So if most of the children are immunized, if it tries to jump from one person once it jumps to the next person, that person is immunized, roadblock. It jumps to this other person, that person is immunized, roadblock. Okay, succeeds in getting to one person who is not immunized. It catches with that. It tries to jump to the next person, roadblock, maybe until that person is cured. So herd immunity, in public health, we know that when at least 80% of any particular society is immunized, then that is sufficient to cover the rest. That's called herd immunity. All right, so when we look at our infant mortality rate, okay, see, it has dropped. Well, no matter how we say we've been doing badly, and because actually we want an improvement. But over time, I can say we have made some progress. We have made some progress, even though slow, but we've been consistent with some slow and consistent decline in infant mortality rates. So infant mortality rate, has declined from 100 per 1,000 live births in 2003 to 67 per 1,000 live births in 2018. So in a period of about roughly 15 years or thereabout, we have a decline from 100 per 1,000 to 67 per 1,000 deaths. Even though 67 per 1,000 is still considered high, because when you compare that to developing countries, you used to have, some of them is 1 or 2 per thousand, and we are having 67 per thousand. Okay, so we can see, say it's tolerable, it's declining, but it is slow. This within 15 years. Then under 5 mortality rate also declined from 201 per thousand live birth in 2003 to 132. Okay, so to 132 in let me. All right, so 132. So that's also a decline. Then neonatal mortality rate has also declined from 48 per thousand live births to 38. Now, neonatal mortality is, neonates are people who are born within just 1 month of age, okay? All right, I'm seeing that, okay, I even have a further decline from the new latest NDHL, you see, a further decline from the National Demographic and Health Survey reports. Okay, so Nigeria is also made more decline. So I'll update this that up to 2024. So you can see that there's some progress being made. There's some progress being made in the last 20 years, with maybe from 100 per thousand live birth to about 41. There's a progress, there is progress. So we want this progress to continue. And what is responsible for this progress is if the health sector is well managed, if the health sector is responsive, accountable, making sure children have vaccines, as at when due. Okay, making sure children have vaccines as at when due. It helps a lot. Okay, so if we want to achieve our SDG 3.2 to reduce neonatal mortality to less than equal to 12 per thousand live birth, then we need to work harder. We need to work harder because right now we are not on that target. We are not on that target because 2030 is just the next 5 years, and to reduce, for instance, from 28, I don't know, 38, I don't know what the exact number is now, so that is still tall. It's a tall order. Okay, so this is the same data but graphically presented. So you can see the decline in each of them, gradual decline. Okay, when I update it, if I update it with the last NDHS 2023-2024, I will notice, I will see what, I will update it to see where it will have gone by then. But this one you see from NDHS 2023 to 8 like that. Now there's a new one that is just out, so we'll put it to that. Okay, unfortunately, although understandably, Nigeria has the highest number of unimmunized children in Africa. Well, you can see about half. The graphic says it all. Half of the unimmunized children in Africa are based in Nigeria. There are several reasons that can account for this. One, our population is high. Okay, our population is quite high. And we also have reasonable resources, no doubt. But very importantly, apart from the high population, our healthcare system is a bit still vulnerable. And to make things worse, we would have done better if we had less of insecurity. Insecurity now is also now contributing to this problem. So that's where we are. Insecurity is also now contributing. So we need to up our game. And unfortunately, majority of these children are in the northern parts of our country. And that is where most of the insecurity is. Not to say that insecurity is not everywhere. It's everywhere, no doubt. The East, unknown gunmen, everywhere there is insecurity. Even in River State here, there are a lot of insecurity. So it's affecting immunization coverage. It's affecting immunization coverage. Okay, so we use DPT, we used to call it DPT, that's diphtheria, pertussis, and tetanus injection, antigen, but now it's penta-3 because of other antigens is now 5 antigens together, penta-3. We use penta-3 to assess immunization coverage. It's like a convention. So when we want to look at, say, what is the immunization coverage in Nigeria, one of the easiest things we can do is to look at penta-3 coverage, penta-3 coverage is just what we use, is what is adopted, officially adopted. Why as all right. Now, there are 5 types of vaccines commonly used, 5 of them. The live vaccines, in fact, maybe because of this network, let me off. The live vaccines or live attenuated vaccines, they are live viruses, but weakened. That's the attenuation. Most times they are weakened with formalin or some other chemicals, or ultraviolet rays also. There are mechanisms whereby they are weakened. So when as they are weakened, they lose their ability to cause disease. They lose their pathogenicity, okay, the ability to induce or cause disease, or their virulence. Then at the same time, but at the same time, they do not lose their capacity to cause immune response. So they retain their immunogenicity and lose their pathogenicity. That is their characteristics. Examples are BCG, yellow fever, oral polio vaccine, and measles. The examples that in our schedule. If not, there could be other examples. We will limit ourselves to the ones our national program. Then we have killed or inactivated vaccines like the pertussis, cholera, typhoid, and the IPV, the inactivated polio vaccine. There are two types of polio vaccine, the oral polio and the inactivated polio vaccine that is injectable. Then you have the one they call toxoids. Toxoids, diphtheria, tetanus. Toxoids are the ones that are made from, the components of those bacteria. Then you have the conjugate vaccines like pneumococcal conjugate vaccine. Then you have recombinant vaccines, hepatitis B, human papilloma virus vaccines. Those are recombinant vaccines. So they are in groups, okay? These are groups of vaccines where you could just, then this is the immunization schedule. Immunization schedule. A lot of you who are healthcare workers, well, you just look at them. Most of them, some of them are being modified again. Some of these things are not cast in stone or in marble, as they say. The reason is that based on epidemiological evidence, countries can modify them. Even in our own country, we have modified. You see, we have, like now, we are now giving a second dose of measles. But for many years, when I even in practice, measles was only at 9 months, but now, so it can be modified. Okay. Then the current immunization strategies we have two. One is the routine or basic immunization. I should have called it number one. Routine or basic immunization. That is this one, routine or basic immunization. That is this type of immunization or vaccination children have when children are born. The parents, the mother in particular, takes them to the health center routinely every month to receive vaccines based on the schedule of appointments. That is basic immunization. So the strategy used to give those ones are fixed post strategy. The hospital, the health center, the health facility is the fixed post. We can also use outreaches to give these ones, whereby the healthcare workers take these vaccines, go to the communities, go to where the people reside, and give to them. Then the other approach is the supplemental immunization activity taking place, right? Over the maybe weekend, you see healthcare workers with their aprons and, and their vaccine carriers moving about and vaccinating children. So the supplemental include for oral polio, for polio eradication, we use the NIPDs, that is National Immunization Plus Days, where the entire nation declares immunization, then we use the state immunization plus days. Initially, it was NID, National Immunization Days. but later it was changed to NIPDs because of the monotony, in the sense that a lot of people started preventing their children from receiving the vaccines. That eating not too much every time, this same vaccine. So in order to make the vaccine program attractive, other things were now introduced. For instance, deworming the children, giving them what do you call it now? This food supplement, vitamin A supplementation, okay, vitamin A, and use the opportunity to distribute a few drugs like oral rehydration salts and all that to mothers. So that is why it's now immunization plus days. Then you can, if it is limited, if it is the country-wide, it becomes national, state, it becomes state or local government. Then there is something called a mop-up immunization. Mop-up immunization happens also when in certain situations, maybe a sudden outbreak of a particular vaccine preventable disease in an area, a vaccine preventable disease that is epidemic prone. Maybe it just happens somewhere in Port Harcourt, but we immunize the entire River State, because that is wherever it has reached, we just try to contain it at that point. So you can use some mop-ups. Then for measles, we have the measles campaign, but many of them now are all merged into this neonatal infant week, which I'm trying to remember the name, which we do annually, there's National Maternal Infant Neonatal Week, which we do. We do use the opportunity to do a lot of these immunizations, like yellow fever, tetanus, and all that, cerebrospinal meningitis, and all that, okay? So that's for vaccine. Then for other non-communicable diseases, we have TB, we have leprosy. Oh, somebody's saying no sound. Yeah. Maternal infant child, no, it's it's maternal neonatal child health week, yes. Maternal neonatal child health week. Okay, so we use this opportunity to immunize children. Okay, these are various strategies. Then we have the thank you, I've seen the correct name. Then we have the TB, which is another major communicable disease in our environment. TB is a problem. Okay, it's caused by Mycobacterium tuberculosis, affects the lungs most often than any other part of the body, but that does not say that TB does not affect any other part of the body. It does. It does. It affects almost every organ. So TB is spread through the air by a droplet infection. Droplet, maybe through sneezing, coughing, spitting, right? A droplet is not airborne, it's droplets, it drops, it's not airborne, it's not spread in the air per se. If it pushes either through sneezing or coughing, it drops after a while because it is heavy. The molecule is heavy. That bacteria, the droplet nature, a lot of moisture, saliva around it, so it drops. The weight is more than 10 microns, 10 microns. So by gravity, it will drop more than 10 microns. So it can be healed. So TB is a very serious disease, but very completely curable, right? So now there have been, over time, upsurge of TB because, of course, HIV. And because TB now tend to relate because of immune depression with HIV. Wherever we suspect, wherever we see TB, we must screen for HIV. Wherever we see HIV, we must screen for TB, because now both of them are like Siamese twins. They go hand in hand. With the advent of HIV globally, there was upsurge of TB. The simple reason is that many people are infected with TB, many in the society, but the TB has the capacity to be latent, can remain dormant in the lung or any part of the body for many, many years. So the body's immune system usually keep them in check. But if for any reason the immune system wanes, the immune system depresses, maybe some very acute illness occurs in that person, or chronic illness, or gradually the person become aged and his immune status begins to weaken, to wane, then TB can come up. All right, so that is, TB is a leading cause of people with HIV. It's a leading cause of death among people living with HIV. So for that reason, for among people living HIV, we used to now give TB prophylaxis. So most people who fall ill with TB live in low and medium income countries. But TB is present all over the world. TB is present globally. It's just that we have the high burden of it, and it's explainable. Our health infrastructure is weak. So our health system is weak. Now, about half of all people with TB can be found in 8 countries of the world. Imagine when we have about 198 countries, 50% of the people with TB are found in just 8. You can imagine that. Bangladesh is leading the pack. China, India, Indonesia, Nigeria, Pakistan, Philippines, South Africa. South Africa became prominent because of HIV. You see, about a quarter of the world's population is estimated to be infected with TB. Well, being infected with TB bacteria does not suggest that the person has a TB disease. Please take note. The same thing with if being infected with, if a blood test is done on almost all of us who are participating in this lecture, if our blood is sampled for malaria parasites, you can see that almost 90 to 100% of us will have malaria parasites. But that does not suggest that we have malaria. That's how it is with TB. They can be kept in check by the immune system, right? But when the immune system weakens, for either because of one stress factor or the other, then the bacteria can have the opportunity to emerge. Only 15%, 5 to 15% of people fall ill with active TB disease. So you can see, while about a quarter will, a lot of people will have it, only about 5 to 15% will fall, active disease. So they are all being checked. So the rest have TB infection but are not ill and cannot transmit the disease. Both TB infection and disease are curable using antibiotics. Okay, these are just facts about TB in terms of the numbers. Okay, so you can just read them up. So, but when it comes to TB, the greatest challenge we have is the MDR TB, multi-drug resistant TB. It remains a public health crisis and a security threat. Nobody prays to be classified or into this group. It is very difficult to cure and a more prolonged cure. Although the medical science has done, medical science globally has done a lot of work, a lot of research. When we started treating multi-drug resistant TB, even in our center here in Port Harcourt in about, I think 2014, when we started, I was involved in that center. Okay. The treatment was 18 months, but today we are treating for 8 months. 18 months of hospitalization, compulsory hospitalization. 18 months of compulsory hospitalization to treat multi-drugs. So that's quite, but today it's been reduced because of the newer drugs to 8 months and now referred to community management. You see, so globally, TB incidence is falling at about 2% per year between 2015 and 2020. And of course, now, so we say that it is falling. Part of the reason is that, now we have a better treatment strategy. This screening of HIV patients for TB, a lot of, enable us identify a lot of cases and the effective treatment, okay? Effective treatment, rifampicin and INH, isoniazid, rifampicin, and all the rest, ethambutol and all that. So there are drugs, but what the strategy here is that we never encourage people with TB to seek private treatment. No, it's a disservice. One, the treatment is completely free at no cost, or not 1 naira, absolutely free. That's what the country has done. Absolutely free. The reason is that for most important public health interventions, those ones that are a great risk to the society, they are treated free of charge. Because, for instance, if somebody has COVID-19 and he comes to the hospital to say he should pay 100,000, he say, I don't have now, I'm going home. And that going home means spreading it to other people. So the government are undertaking like epidemic-prone diseases are treated free of charge, treated free of charge. But the challenge we are now having is to get people to avail themselves to, instead, maybe because of stigmatization, some people want to go for private treatment, which is not advisable. Why it's not advisable is that in the public sector, these healthcare providers are specifically trained. For instance, in our department, our people are specifically trained. We run the DOTS clinic for TB. Our residents, our senior registrars are well trained on the national protocol on how to handle it. All the drugs are there. Everything is there. The training is from time to time. But somewhere in the private clinic, you see the doctor has not, apart from what he had in the medical school, in the past 10 years, not gone any training on TB, and he's the one managing. Then the person is booking to death, to mortuary. Yes, I say so because, you can't give what you don't have. That is one. Two, access to the drugs can be very difficult because these are drugs gotten from bilateral agreement, Nigeria and some of these other countries and the pharmaceutical companies. So they are not sold. They are not sold. It's not what you openly, you can have in the open market or whatever. It's not. You cannot. They are programmed drugs. So the best bet is to just go through the program, Okay, we talked about the transmission is by droplet infection, okay, particles and all that, coughing and all that. So we have two types, the bovine and the human type, the bovine TB and the human TB. The bovine TB is the one that affects cow and pigs, all right? Okay, and the human, the one that affects humans. So communicability. One interesting fact about TB is that patients are infective as long as they remain untreated. Once patients are not treated, they remain very infective. But the good news is that immediately an effective treatment is introduced, the infectivity That is the ability to infect others, or the virulence is reduced to 90% in 48 hours. It reduced by 90%. So if maybe, which means once a treatment is commenced, the individual within 48 hours loses ability to infect other people. So if treatment is commenced, say, for 100 TB cases today, by next tomorrow, 90 of them will not be able to infect people. Only 10%. So this is only just telling us how effective those drugs are. Those drugs are very effective. In a short period, they can, they can make a lot of difference. While the incubation period is anywhere from 3 weeks to 6 weeks, and the disease is slow in development, so that if people do not take their time, you will not notice their development. But the clinical features, for any experienced somebody, will notice it. But most important clinical feature we look at is cough. Prolonged cough at least 2 weeks. Initially, we used to say 3 weeks, but you see, things are changing. That is why in medicine, we are always updated with a lot of training on training. Our trainings don't end. As long as you are there, it does not. Even today, I went through a training. Either somebody is training me or I'm training somebody. That's how it is. Those of us in the teaching hospital. Well, if you're in a private clinic, sorry for you. You will remain with what you know. After 5 years, you are a chemist man because you are not training. So we train and get trained. That's the way this thing is. So prolonged cough. Before we used to say 3 weeks, but evidence now suggests 2 weeks is enough. Chest pain, weakness, fatigue, and all that. However, there are some of them that can be controversial, which means you must be very careful, like night sweats. When the weather is hot, people can sweat. That doesn't mean that they have TB. So it's a combination of factors, or you see somebody who is sweating now, you say this person will have TB. No, please, there's nothing, nothing like that. So we need caution. Okay. So that is how it is. Now, the symptoms are usually mild, and that could make people not seek treatment early enough. And in the process, since they are not seeking treatment early enough, they spread it. That's the danger. Some of these, the public health concern. But very acute diseases will compel the person to take treatment. For very acute ones, you have no choice. Okay, diagnosis, there are a variety of diagnostic measures these days, but the gold standard still remains our chest x-ray, okay? Suspected cases, now there are other cases where we even use rapid tests like TB Lam, urine, even gene expert, okay, and all that. So these are tests that are recommended by WHO, okay, or sputum microscopy. Sputum microscopy is actually, is the gold standard, not chest x-ray. Sputum microscopy, that is the bacteriology, the culture. It takes time to culture, because of the time. Most times when you collect the samples, you don't wait for all those things. It used to take up to 4 to 6 weeks before you can culture it. People with TB sometimes do not show any signs of sickness. So that is why many times we also do screening when we are doing active case finding. We do screening at these patients that are at risk. As I said, patients with HIV, for instance, you screen to identify their status. So look at the methods: intensified preventive and control. One, intensified case finding, either facility or community-based case finding. Even in the hospital, we have active case finding. So from our general GOP, our general outpatient, and all the entry points, A and E and all that, all the entry points, we do case finding using some checklist. Screening, we can use Gene Expert, TB LAM, and all that. Then we can do tuberculin testing, mantle test. You can use our drug treatment, which is DOTS. DOTS means directly observe treatment short course. Directly observe treatment short course. That's DOTS. Here, the aim is to directly observe the patient taking the drugs. That's how important it is. So, particularly in the first 2 weeks or thereabout. So we'll make sure we render the person in how do you call it? How do I put this grammar now? Inability, make the person unable to transmit the disease. Okay, make sure that so for us to be sure that because you can give some people drug, they throw it away. So we have to provide. We say, okay, bring water when you are coming. Bring but one small bottle of water, 500 mils. You take the drug before us. Things like that, just for the first a week or two. When we are now certain that the communicability of the disease is now impaired, then can release the person to be taking his drug. Of course, using treatment supporters, the significant order, that kind. Because the reason is that when people get better, people can be very sick of TB, extremely dying, and just 2-3 days, 1 week of treatment, they have come back to life. It will look as if they were never, they will get strong. At that point, some people can drop the treatment, and that can be dangerous. They believe that, oh, they don't finish it, I'm okay now, and all that. So for that reason, we use counselors, we use counseling and get a significant other who support this person at home with reminder, insisting that the person takes his or her drugs. Okay. Now, HIV, well, this is one we know a lot already about. And when we read, we can easily understand, because a lot is being said over the last couple of years because of the nature of the stigmatizing nature of the disease. Human immunodeficiency virus is a retrovirus. It's a retrovirus. This virus breaks down our human immune system by attacking the body's CD4 cells. The CD4 cells. And once the CD4 cells are attacked and weakened, once they attack, it weakens our body's ability to defend itself from other invading bacteria. Okay? So, and once that body is weakened in that essence, it gives opportunity for other infections. We call them opportunistic infection. Why are they opportunistic? They took advantage, they took the opportunity that the body is weakened to emerge, to manifest themselves. They took an undue advantage, because when the immune system was strong, they could not penetrate. So that's why we call them opportunistic infections. Like TB is an opportunistic infection. in patients with tuberculosis. Fungal infections are also opportunities, Then a lot of others, neurological disorders, and some unusual carcinomas, malignancies like Kaposi carcinoma, Kaposi sarcoma. Okay, Kaposi sarcoma is a skin disease or that is very rare, found in elderly and people suffering from very chronic kidney disease, cancers, and all that. But when we begin to see Kaposi sarcoma in young people, then it's as a result of depressed immunity. Okay, as a result of depressed immunity, it's a skin type of infection. So, but we know much about HIV. Transmission is by exchange of body fluid from an infected person, okay, to uninfected. And the body fluid include breast milk, blood, semen, vaginal fluids, and all that, okay? Then, however, it is not spread by kisses, hugs, and any of this sharing of utensils and all that. Okay, it can also, of course, be spread from a mother to a baby if there is no opportunity for treatment during pregnancy. That is vertical transmission. If there is no opportunity for treatment, particularly it's spread mainly at the time of birth. Okay, so that is why many times when women are pregnant with HIV and are HIV positive, we opt more for a cesarean section. Okay, there are protocols for this, but these are clinical things. I don't think I should bother you with them. You are doing more of public health. Okay, so the statistics are there. The important thing to note now is that over the years, there have been a decline in prevalence of HIV. There's been a decline in prevalence of HIV. Even in countries where there was high burden. Even in Nigeria, the last time I think we had is 1.4 million or so, 1.3 or thereabouts. So there's been a rapid decline over time. Now, the current target by UNAIDS is that is the 95, 95, 95 targets, 395. So the first 95 is by 2030 that at least 95% of the people should know their HIV status, right? Should have been tested and know their HIV status. The other 95 is what? Who knows? Who is in HIV programming among you? The other 95 should be what? Put it on the chart. Let's see. 95, 95, 95. Okay, go ahead, Nelly. Okay, put it, maybe I don't know if you're muted, so just put it on there, listen. 95 should know their status. 95 should be at least on treatment, and 95 should achieve viral what? Suppression. Okay, thank you. Well, that showed me there are programmers in the midst, so you know most of this. So 95, 95, 95 targets, that's what globally, that's what is a global target. So we are striving. You will see where we are as at the last count, I know. When we evaluated the 2020, Nigeria, we were able to achieve one target. That is, people living with HIV know their status. We're able to achieve 90%, right? When we are having 1990, that cascade. Then people living with HIV on treatment, we are not unable to get all. We were able to achieve 86%. But people living with HIV with viral suppression, we are unable, we only had 72%. So we didn't meet quite the target at that time, but we are hoping that this time we'll meet the target. So our country is actually doing well. But there is a place we are not doing well, and that is in pediatric HIV. We are not doing well in pediatric HIV. We are still very, very, very low in pediatric HIV. Okay, so now in pediatric HIV, we look at the targets, estimated number of pregnant women live with HIV who receive ARV is just 44%. I don't know the exact what it is now, but I can find out. So so the risk is that if they are unable to receive ARVs and they are unable to have cesarean section, then there's a problem. Vertical transmission, transmission from mother to child, can occur. Then estimated coverage, ART coverage in children is still very low. While we're having 89% in adults, we're having only 45% in children. So we need to do more. Okay, we need to do more. Our strategic framework there, we have our national strategic plan, the AIDS-free and AIDS-free Nigeria with zero new infection, zero AIDS-related discrimination and stigma. That's our national strategic plan. Zero new infection. That is incident rate zero. I told you earlier on that in some of the lectures earlier on that one of the ways we used to track a program is by monitoring the emergence of new infections. Okay, so new infections. All right, so these are just provisions of the strategic plan. You can take your time and read them. You have them already. Then hemorrhagic fevers, Lassa fever as a problem. Lassa fever is an acute viral hemorrhagic fever. It is caused by the Lassa virus and it's a member of the arenavirus family. Okay, this virus has caused a lot of epidemic in many countries: Benin Republic, Ghana, Guinea, Liberia, Mali, Sierra Leone, Togo, Nigeria, and other West African countries. It was first discovered in a place called Lassa in Borno State, and it was found it's a virus that usually occur in exposed food that has been contaminated by either urine or feces of infected mastomys rat or Mastomys natalensis. Mastomys natalensis. That is the name of that rat. Mastomys natalensis, or the multi-mammate rat. From that natalensis, multi-mammate rat. But who cares? Who goes to begin to count the breasts? It's a multi-breasted rat. To go and count the breast of rats. Maybe those in virology and those can do that, not for us in clinical medicine or in public health. All we need to know is about, in fact, just avoid, we're not ready to count the breast to know whether it has multiple breasts or not. So here, the transmission is by person to person, and it can also, laboratory transmission can also occur. So any of you who is a laboratory scientist, you have to be very careful, particularly those in virology. You have to be very careful, it can be transmitted. So in healthcare settings, it can be, especially because of everything, poor PPEs, everything inadequate, it can also, be transmitted. Okay, so that's it. Diagnosis and prompt treatment is essential. For now, there is no cure, no known cure. What is actually treated with the drug ribavirin? Ribavirin is not actually a proven remedy. So case fatality is about 1%. So it's not, the case fatality is not very high, but that is in good centers, but can be very high in, poorly managed centers. Okay. So this giving you about the key facts, the illness, hemorrhagic fever, 2 to 20 days duration, you can, the transmission rate and all that. So you can just read up this. So prevention is promoting first individual, household, community hygiene. Make sure food and other edibles are shielded away or stored in such a way that rats don't have access to them in rodent-proof containers. Okay. In some areas, Mastomys natalensis are very endemic. In certain parts of Nigeria, like in Edo, northern part of Edo, again, those areas is, in fact, that made the country to set up a Lassa Fever Research Institute at Irua Specialist Hospital. That's a major specialist hospital for Lassa fever. It used to just be Lassa Fever Research Center because we have so many of such in those. And part of the reason is that people spread their food products on the street for drying and all that. And rats rodent from the bush take advantage to go and feed. In the process of feeding, they contaminate, and the people will go and eat those things. So family members should always be careful and avoid contact with blood and body fluids of people who are caring for the sick person. Even for those of us who are clinicians, normally, of course, in our department, it's managed in our center. It's managed in our center. Professor Maduka is the facility manager in our special treatment center for infectious diseases. So they are well kitted, everything is provided. The resident doctors who care for such patients whenever they come, we make sure they don't lack any of those preventive measures because any of them could die from it. Some have died before, some of our doctors that I know very well, from getting infected. So we need to, normally whenever we train them, we train and train and train. And make sure that they are familiar with the procedures so that they don't become victims. So we make all the PPEs available. We make sure the way the samples are taken, to the laboratory, make sure the laboratory, those, like we have a molecular laboratory so that where it can be analyzed. But for now, we make sample transport to Irua, but I don't know the latest. When I was in charge, we were using Irua, but I don't know if our molecular lab is now equipped to do it. Okay, so healthcare workers seeing patients suspected to have Lassa fever should immediately contact local and national expert advice. Once we suspect them, please, we must advise. We must report. No health worker is permitted to begin to manage. It's not the type of thing you manage in one private clinic and keep quiet. No. That is why when we are training our doctors, we train them well. Here I'm rushing. If in the usual clinical setting, we won't rush like this. We train them very well to recognize everything so that they can report to protect the society. And immediately an alarm is raised, the entire public health machinery is put in place in just hours. That can assure you we do that in hours. Maybe 2-3 hours, emergency meeting is called, machinery is put in place. And that is why in Nigeria, we have successfully many times contained our epidemics once we have a report. Then the COVID-19, well, I think here you are all experts about COVID-19. Read it up, Avec. because you are all adults, you saw it, a lot of you know what happened. You were using masks, you are maintaining distance. You are using, some of you use cloth mask, some of you use surgical mask, some of you use N95 mask, okay? So here is COVID-19 is a coronavirus, 2019. That's actually what COVID-19 means. Coronavirus 2019. And that is just talking about the coronavirus species that emerged in 2019. So that's that name, COVID, coronavirus 2019. Okay, it's shortened to call it COVID-19. It's a coronavirus. There are several coronaviruses. It's just one of the, these common symptoms are fever, chills, sore throat, okay? And there could be a range of other diseases, fatigue, body pain, and all that, okay? A lot of people recover without actually needing hospital treatment or hospitalization. But some people, the sickness can be, this thing can become severe. It can become severe. The world lost a lot of people, okay? And a vaccine was hurriedly produced. Okay, I believe all of us are vaccinated. I am fully vaccinated. So but those of you who are not vaccinated, well, I don't know what you're waiting for. So it's always important to keep physical distance of at least a meter, 1.5 1.5 perhaps, because these things are average, based on research. Some are more. So in Nigeria, we are preaching 1.5 meters. A meter might be too small because we're not sure. We need to be more sure. Okay. Avoid large crowds. But at times it's difficult to avoid large crowds because you will go church in a night vigil and all that. So, or you are in some of those crowds, or you are attending a political rally, for those of you who are in tune with those, So normally we advise that you use a properly fitted mask, maintain distance, and good personal hygiene, a lot of hand washing, okay, a lot of hand washing, and where it's not possible, use alcohol-based hand drops. So, we were collecting sanitizers, the alcohol-based hand drops and soaps to wash. It's always good to cover mouth and nose with, with the elbow when one is sneezing, okay, and all that. So these things are there. So thank you very much. I think that's the end. If you have any questions, you can quickly ask. Why did I say that is funny? Somebody is laughing. So you can ask, then we look at them. So that's it. Okay, so all right, so you can unmute everyone so that now we can ask questions and call it a day. We can mute, yes, so we can ask questions. So I'm okay, fair, okay, Peter, I did you do whichever, I'm sorry. Then after which Adekunle, Daniel, then Cyril Wale. Let's go in that order. Go on, unmute, please, host. Okay, I'm the host, oh. You made me host, okay. Let's see. Okay, mute on.
Okay, thank you, Prof. Good evening for the sweet
yes.
college. Okay, I think, Prof, let me start by saying I learned a new and very important thing today. I was taught that tuberculosis is a born disease. I was taught that tuberculosis is a born disease.
No. It's not. It's a droplet infection. You know what is good? Look, please, all of you should look airborne, and it is good to you are conversant with this terminology because people can confuse you. Don't allow them confuse you with their own ignorance. Airborne means it is carried anywhere. For instance, if a disease is airborne, it can from here go to England. It can go from here to China. There are some diseases like that, like SARS, severe acute respiratory virus, There are a few like that that are airborne. The avian influenza, they are airborne. But droplet is that if you go into the air, because of its heavy weight, it will drop. By gravity, if you throw something up, it comes down. So it will not go far. The same thing with COVID. That is why I say maintain 1 meter distance. I am saying, please maintain 1.5, or if possible, 2. Because you know that if the person coughs or sneezes, that projectile that pushes it out will not remain in the air forever. It will drop under gravity, because COVID is also up to 10 microns by weight. The other ones that are airborne are the ones that are 2.5. Those ones will call them respirable. Respirable. Those ones, when they are inhaled, they can go down to the alveoli of the lungs. Those are respirables. These other ones, they are like, you see, at times you see when you pass where they are burning something, soot, you look at your nostril everywhere, soot, good. They cannot go beyond those places. Remember, there was a time that soot, like in Port Harcourt, soot everywhere, soot, you see, they are not as dangerous as it was made to see by the media. But we who are in the, we know they are not as the media people project it to be, because we know technical characteristics of those particles, suspended particulate matter, or all those, SPMs. All right, go on, Adekunle Olarewaju. Unmute yourself and talk. Then go on. Let's call it a day.
Prof, thank you very much. I really enjoy your lecture, sir.
Thank you.
Yes, sir. So my question is still on tuberculosis, sir.
Okay, go on.
In the immunization clinic now, we are giving a BCG to children.
Yes.
Sir, after taking this BCG, is there any future occurrence that such children can still be reinfected with TB?
Thank you for the question.
Thank you, sir.
Really, after the BCG, the chances of the child getting TB is very rare. Is very rare, right? But it is possible. Let me tell you the teaching. The teaching now is that the TB protects the child generally from TB, but most protective of the child of complicated TB. There's a name for it. I'm just escaping. That is like miliary TB. There's something called miliary TB, or TB encephalitis. Miliary TB and TB encephalitis. Those miliary TB and TB encephalitis are very severe forms of TB. So, in terms of theory, what you should now take away, and all of you from this, in case somebody asks you this question, and the question is that if somebody is immunized with BCG, can the person still have TB? The answer is what? Yes. But the person will not have severe TB. So, in effect, in essence, that what do you call it now? BCG protects against severe form of TB. Do you understand? Severe TB. That is what it protects. Severe TB. And examples of is miliary TB, that is miliary tuberculosis, and TB encephalitis. Does that answer your question? Okay. So that is it. Next question, Cyril Wale. You have your question. If it's not there, let's have Cassie Davids. Oma. Because there are several. Open and talk. Are you unable to talk? So that I know where the problem. No, it's open now, so. Okay, now if somebody is not able to talk now, let's go now. What are we doing here? Christopher is saying.
Yes. Okay, sir, I'm back, sir. Hello, sir.
Go on, who is talking now?
Cassie is talking.
Good evening, okay. All right, go on quick. I was calling. Go on.
All right, sir. So, sir, thank you for the lecture. So I was concerned about malaria, when we are talking about malaria. Yes. So for you talked about that malaria is dangerous for pregnant women. Sir, yes. Please, I would have loved to know exactly why malaria is that dangerous for pregnant women. Then the second part of that question is this way, sir. You said that for children born from 0 to 6 months, that they have some level of strong immune resistance, so to speak, resistant of malaria. All right. So, but we are told, so to speak, that malaria even kills children in the womb. So I don't understand the should I say relationship now. A child in the womb can be cured of malaria, but when the child is born from 1 to 6 months, he has some level of immunity. So please, sir, can you shed a little bit more light, sir? Thank you.
Okay, thank you very much for your question. All right. You are saying that what was the first question, Seth? Because there are two. You talked about sorry. Okay, let me correct one this thing. I told you miliary TB and TB meningitis, not encephalitis. Well, meningitis can affect those are severe forms of TB that the BCG prevent. Okay, coming to malaria. You see, the malaria in pregnancy, it can lead to abortion. It can cause a woman to abort a child. Okay, and that is what is being prevented. It can lead a situation that contractions and expel the child. So malaria in pregnancy, malaria causes a lot of anemia. Okay, malaria causes anemia. That is the cardinal feature of malaria, anemia. It breaks down the blood cells, and you know that the most important function the blood performs is carriage of oxygen. Oxygen perfusion. Oxygen perfusion is one of the cardinal functions of the blood. So it moves oxygen to all the vital organs. So it can kill a child in the womb if a child is starved, of oxygen, the cells. The child is not breathing, but that oxygen is through the umbilical cord, right? Through the placenta. Okay, so that can occur. But when the child is born, the means of malaria in the womb and that when the child is born, they are not the same exactly. The child now needs to be beaten by malaria parasites, mosquito that will transmit the parasite, okay? But at that time, I told you that by transference of passive immunity, you can see that some people suffer malaria more than others. I don't know if you have observed it. Some people can tell you that in the past 1 year or 2 years, I've not had malaria. Another person will tell you that they have malaria every month. Why? Their susceptibility, their immune response are not the same. We have categories of persons, maybe because of their genotype, they suffer malaria more than other people. So immune response matters a lot in any infectious disease. So because of that, when children are born, there is some form of immunity that is transferred from their mother to them. That's how God made it. That prevents some of those infections. But those immunity don't last. Okay? They are usually very temporary. And that is why we need to immunize the children by actively injecting antigens to them for their immunological substrates to produce antibodies, right? So when the child is born, he has that protection in the first 6 months. After that, that protection wears out. The child can now become very prone like any other person. Okay, so that's how it is. There are immunological mechanisms that are beyond this lecture. Okay, so that's how it works. But just believe it by faith because that's the truth. All right, the next person is Samira after Jerry, Gina, and Juliet. Quick, unmute yourself and speak. Ask your questions.
Good evening, Prof.
Good evening.
This question, Prof, thank you very much for the lecture. Still on malaria,
okay.
You made mention of malaria vaccine not being 100% preventable.
Yes.
So why is it recommended since it is not 100%? And
no.
also, is a class.
Do you have an alternative? So will you say, because see, let me tell you about science. Science is dynamic. And that is why there is research round the clock, round the world, globally. You can't wait until you have 100% before you roll out. Now, for instance, I said you're about 67%. Or maybe the research is still going on. Maybe in the next 5 years, right, either this very vaccine improved or maybe another one that has better efficacy, comes up. Look at when we started treatment with HIV, for instance. The drugs were so toxic and so, a lot of people left the treatment because it's like, I beg, this medicine will kill me, even the disease, because at that time, they are not even feeling much of the disease, but the drugs were so toxic that you need to be very courageous to take. But today, with the current drugs now, we don't have problem. Look at our clinic full of people. With current drugs, people just seamlessly, The side effects from those drugs were so much that discourage people from taking them. But today, with with the latest drugs that are in use now, so you cannot say because it's like that, oh no. Even if it is 50%, half bread is better than none. You can imagine the situation, okay, you gave 100 people that vaccine, 67 of them are protected. Okay, 33 are not. You can't say that, okay, until I wait until all of them. There is still work in progress. Let me tell you, most of the drugs you are taking, the efficacy are not 100%, in case you don't know. In case you don't know. Yes. Because you don't know what is in, you just swallow, it work for you, you don't know what is there. I know. All right.
Thank you, Prof. Please, Prof, what class is the vaccine among all the class of the vaccines?
Which one?
That is the malaria vaccine. What class does it belong? What type of vaccine is it?
Okay. Because it's Plasmodium. I'm not sure. I will find out. I will find out that I've not even looked at it. I've not really looked at it, but I will go to the books tonight, maybe, and if you remember tomorrow, maybe I can find out the particular type where it belongs.
Okay, thank you, Prof.
But it's not a virus, so it's either belong to killed or inactivated. That's where I suspect, or a toxoid. That's most likely, but I will find out.
Thank you, Prof.
All right, thank you. Who is the next? Is this Samira? Go on. If you don't, then okay. Jerry Dina. Okay, Aisha Bawa. Okay, course rep.
Sir, good evening.
Yeah. Good evening.
Samira here.
Okay, go on.
So please, during your presentation, you made mention of every individual has a TB bacteria in your system, but you need a certain condition when your immune system is being compromised. That is when the bacteria can be activated. I was told that anybody with HIV needs to take, without TB, needs to take TPT, which is the TB preventive therapy to prevent from not getting the tuberculosis, which is in the form of isoniazid. My question is, since we have the bacteria but it's latent, can we also take the isoniazid to prevent future occurrence? Thank you.
No need. No need. You see, in medical practice, drugs are given based on indications. Once those drugs are not given based on indication, it will cause resistance. That's why we don't. If it is latent, it is because, in fact, even that, it will not, you are just taking it for taking sake, it will not do much. The reason is that, you see, because of our interaction in the society, we go to a religious crusade, we sing and shout in the churches, we ride in public transport, bus and all that. We go to stadium, people say, hey, man, this, and things like that, or gathering among friends. A lot of these things are emitted. We pick them up because they are microscopic. We pick them up in little doses. And our immune response, our immune status will just engulf them. Our system will hold them. That is why when, for any reason, any person who is not reactive to tuberculin test, it's a danger in the society. We'll quickly give the person BCG injection. If, for instance, any among us, we do a MAN2 test, and the person is non-reactive, it means that the person is not in contact with TB bacteria. It's not even a good result. The person will say, oh, it's not a good result at all, because immediately we look at that person as being a very high risk. Yes. Unlike the person might feel that, oh, I don't have anything. No, it's a misinterpretation of what it means. The person is at higher risk. It's better, it's reactive, which means the person has come into contact and the body system keeps it in check and it can do nothing until the person dies, naturally. So that's how it is. Okay. When we give isoniazid or rifampicin, is maybe if there is high risk exposure. What we see that somebody is high risk exposure, then that can be given for 6 months. And that's, yeah. Okay.
Thank you, sir.
Swakelo Konsi. Go on with your
Good evening,
question.
sir.
Good evening.
Jerry Guinan, sir.
Okay, go on.
Still on TB, I was told that a child that is more than 2 weeks should not be given a BCG. And I want to know why, since it's a child immunizable vaccine.
Who
Secondly,
said so? So that child should remain unimmunized?
That is, has exceeded the duration they're supposed to give a vaccine.
Oh. That one is native medicine they are practicing, not the medicine I know. That the child is a mother. Please discountenance that information. It's very wrong. Completely wrong. If the child is not immunized, you expose the child unnecessarily. It is best the child is given before the child leaves the hospital. The reason is that when a child is born, it's a joyous thing in the family. Everybody, mama, grandmama, they can transfer anything at that time. So we insist that a child should be immunized before leaving the health facility. But it can happen that, there are no vaccines at that time. That doesn't mean that child will not be immunized. I beg, whoever says that teaching is a witchcraft, very wrong teaching. I've never heard of such myself. And I'm a public health person.
Can a pregnant mother that is having TB take those TB drugs?
Of course. Of course. But remember what I said. We have TB control program and it's monitored and it's being implemented in the health facility. And also remember I said that our doctors, our nurses are all well trained. They are specially trained. They work in that maybe like you have not been taught, like our head of department, Dr. Mrs. Ojule. In fact, she is being head of TB unit in our hospital as far as I can remember. She's been trained nationally everywhere on TB. So you can never use her experience managing TB patients to compare with somebody in one private clinic that sees one patient once in 2 or 3 years and is not trained. So it's always advisable to go to the right professionals because all these things are considered even more than most of the questions you're asking here now. Far more than it. Okay, next quick, because I have to leave. I'm tired though. Let the questions come. I'm going to work. I left office at around 3, rushing home. I could get home 4 o'clock, come in 5. I needed some rest too, getting ready for tomorrow. So ask your questions. Okay, any person who raises his hand, I open and ask questions because calling your name, you are not answering. So maybe just unmute yourself and ask questions.
Good evening, Prof.
Thank you. Good evening.
Prof, thank you for the wonderful lecture. Mine is just about the HIV transmission. You said that HIV transmission, HIV is transmitted through contaminated or infected blood products and body fluids, excluding saliva. So it cannot be contacted through tissue. So I am curious. I want to know, is saliva not part of the body, or what is exceptional about the saliva that the virus cannot be contacted through kissing or saliva?
You see, the contact through saliva is not proven. It's not proven. Although people say deep kisses and all that, it is not yet proven. That is why it is not, if it is contacted, there are no cases that you say, oh, maybe the saliva touches you or anything, or maybe you know, it's not actually proven. That is why we cannot pin on it. We cannot pin on it. It's not proven. The ones that are proven are written out. There are some that are suspicious, but there are no concrete evidence that this person got his or her HIV because of through the saliva. Although these days, you know, we have certain reagents to say through saliva, but remember that HIV is about antigen and antibody. The virus is the antigen. The reaction that emanates is when the body produces antibodies. And when we detect the antibodies that are specific for that antigen, we infer that that antigen is there. So it's like maybe you are going through, just imagine somebody going through a bush path and you see that, oh, these are evidence of tire. These are the landmarks of a tire passed through here. But you did not see the car. You did not see the car. But what you saw is those tires. And then you made the inference that a car passed through this place. Why? Because you saw tires. That is what happens with antibody antigen. It is the antigen that gives the infection. The antibody is the evidence that there is an antigen around. So if somebody did maybe saliva test, and that saliva test is an antibody test, you saw antibody on the saliva, does not mean that the antigen is on the saliva. So that is it. So I don't know if that analogy, I try to break it down, whether that is what it is. So the antigen, if you want to assure the antigen, then you do your viral load. You see, just like a CD4, the CD4 count, they are reactive, the antibody test. The antibody test, that is why it's no longer used as, longer recommended as used to measure a tracking of the disease. Now we use direct viral load. You see, but viral load is expensive. The viral load machines are not everywhere and things like that. So at times you can still use this in way if you are in where no way, but the standard now is a viral load. So saliva is not proven. Next question. Next question. Okay, if there's no question, we'll call it a day. Good night, every one of you. We had a nice interaction. So see you tomorrow.
Good night, Prof.
Good night, yeah.